Very detailed. And once you do my review, you're going to pass it. Chris, what do you think after reading some of those questions? Once you do it, and the type of questions and the details, and I break it down and make you remember it, guys, the test writers have to follow rules when they're writing test questions for the NCLEX. One of those rules is everything you need to answer that question has to be in the stem of the question. Once you learn how to identify the stem of the question, guess what? You can get rid of all the noise. Nope, not today. Nope, not today. Thank you. Nope, not today. Then join the live. Say hello. Hello, everybody. All right, y'all. Let me quit playing. Let's get through this. 5:15. All right. Your girl got to go to work. I am tired, y'all. I'm sleepy. All right. Y'all be thinking about what we're going over tomorrow, okay? Because I'm doing student request, okay? Hands down, it's the best. It's better than the test banks. Plus, she helps with what? Yes, that's what I be trying to tell y'all. I created you a test bank of the most missed questions, and I explained to you why people miss them and what you need to know not to miss the question. That's what my comprehensive review is all about. And you got dimensional analysis in there, right? Yep. People struggle with med math, y'all. Med math is easy once you figure it out. Okay? All right. So, remember the 4 T's that cause postpartum hemorrhage: tone, trauma, tissue, and thrombin. Okay? For uterine atony, after massage, you give oxytocin or Pitocin. If that doesn't work, I cannot say this word, methylergonavine or Methergin. Okay? You give Methergin. But here's what the NCLEX trap. We like those traps. Methergin is contraindicated in hypertensive patients. Methergin, which fixes that hemorrhage, it's contraindicated in hypertensive patients. That will be on your NCLEX. It causes vasoconstriction and will raise the blood pressure, right? So then you got carbaprost or Hemabate. I can never say these words. Hemabate. It's contradicted in asthma. It causes bronchospasms. You need to know the contraindications. The NCLEX will give you a hypertensive patient and ask which uterotonic to avoid. And it will be Methergin. Okay? Y'all got it? Are you following me? If you feel me knocking, baby, let me in. One in the chat if you got me. Do you got me? All right, here we go. Thank you, Chris. For postpartum assessment, use the bubble HE. Breast, uterus, bladder, bowel, lochia, Homan sign, and episiotomy. I can't say it. All right? Episiotomy. I said episiotomy. Episiotomy. Lord, I told y'all I'm not a peds nurse. All right, OB nurse. Here you go. Bubble HE. Breast, uterus, bladder, bowel, lochia, Homan sign, and episiotomy. That is how you remember what you got to assess for postpartum. Bubble HE. Okay? The two most tested parts are the uterus and the lochia. The uterus should be firm, midline at the umbilicus right after delivery. It descends about 1 centimeter per day. If it is deviated, I'm not accepting people to come up and co-host. I'm sorry, I'm teaching. If it's deviated to the side, usually the right, it's because of a full bladder. So have them pee, okay? Have them go pee before you massage. Lochia rubra is red, days 1 through 3. Serosa is pink, day 4 through 10. You need to know this. All right? Lochia rubra is red, day 1 through 3. Serosa is pink, day 4 through 10. Alba is white, day 11 through 21. If a lochia returns to rubra after it's been serosa or alba, that is abnormal. If it has a foul odor, that's an infection. You guys know that. If it's stinky, it's not cool. Okay? 2 postpartum infections you need to know. Endometritis, which is a uterine infection. Fever, uterine tenderness, foul-smelling lochia. Okay? Treatment, of course, is with IV antibiotics. And then you got mastitis, which is your breast infection. Okay? It's unilateral redness and warmth, hardness, flu-like symptoms. Here's the most missed OB teaching question on the NCLEX. Should the mother continue breastfeeding with mastitis? Should she? Drop it in the chat. If mama's got mastitis, should she continue to breastfeed? Yes, that's correct. Should she continue breastfeeding or pumping? Stopping causes a what? An engorgement, which makes the infection worse. You give her antibiotics, keep on feeding, right? It's the dicloxilin. That's what they give, okay? And you continue breastfeeding. So this is a critical for mastitis. You got to know this. Continue breastfeeding. This is the #1 most missed OB patient teaching question. Students instinctively say stop breastfeeding. That is the wrong answer and will cost you that question. Continue to breastfeed. Mastitis, keep on feeding. Okay? Quick newborn highlights before we move to part 2. APGAR scores. All right? Assessed at 1 in 5 minutes. 7 to 10 is normal. Below 7 needs an intervention. Jaundice is a physiological jaundice that appears on day 2 to 3. That's normal. Pathologic jaundice appears within the first 24 hours. That is never normal. It indicates a hemolytic disease. It requires immediate evaluation. The timing is everything on this question. Vitamin K is given IM within the first hour of birth to prevent hemorrhagic disease. Erythromycin eye ointment is applied within the first hour to prevent ophthalmia neonatorum. Okay? Time is of the essence. Give mommy a lemonade. Time is of the essence. Not much longer, Skylar. What do you need, baby? Huh?
Do you need this? Do you want this or 0 sugar?
Just give me a lemon. 0 sugar. I'm almost done. Okay? And within the first hour, that's important. If running short on time, cover only. Oh, never mind. Sorry. Never mind. Skylar, give mommy a minute, okay? My daughter's got me over here. IV fluids and types. So we're moving into the IV types because I had a request for this too, okay? Because we're running short on time. That's why I was like, oh, I noted myself because I got to go to work. All right. The mastery concepts, okay, of tonicity. IV fluids. So I need you to understand one concept before everything else. I need you to understand tonicity. 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 It's the concentration of a fluid compared to your blood. Normal blood plasma has a osmolality of about 275 to 295. Okay? Every IV fluid you give is either the same concentration as blood or it's less concentrated than the blood. Or it's more concentrated than the blood. So same, less, or more. And that determines which direction the water moves. I know I jumped right out of that into this, but I got to move fast, okay? Here's the analogy I want you to use. Think of a cell as a grape. Isotonic fluid is the same concentration as the cell. So if you want to remember that, isotonic is the same. Iso. It's the same as me. I'm the cell. Isotonic is the same. Okay? Or make up what you want to make up, but that's how I remember. So we got a grape. Isotonic fluid is the same concentration as the cell. The grape stays the grape. No water moves in or out. Why? Because it's the same. So isotonic fluid, I is good. I stay the same. Okay? The fluid stays in the vascular space. Okay? For the isotonic. Hypotonic fluid is less concentrated, right? Hypotonic fluid is less concentrated. Less concentrated than the cell. Water rushes into the cell because it's less concentrated. So the water rushes into the cell because it's less concentrated. All right? less, it needs some. Right? Hypo, less, the cell needs some. The water rushes in. The grape swells for hypotonic. Hypotonic, don't got enough, so the water rushes in and it gets big. Okay? Hypertonic, it's more concentrated than the cell. Water gets pulled out because hyper, we got too much, we got to get rid of some. Hyper, get rid. The cell will shrink and the grape becomes a raisin. Do y'all get it? Are y'all following me? Y'all got it? You get it? The grape don't change because I am good. Hypo is too little, so I need some. The water's going to rush in and make me go, wah, if it's hypo, right? Hyper, I got too much. It's got to get rid of some. So then I'm going to be a scrunk grape. Does that make sense? Does this help you? I know I'm goofy, but I hope you sit and you see me in your brain doing all the sounds and the grape and the scrunks and all the stuff, and you remember it. I want you to remember it. All right, good. Good. All right. This is not just a memorization fact. All right? This is a clinical reasoning. When your patient is dehydrated, all right, and in shock, what do they need? They need volume. Okay? They need volume when they're, hang on, I got to get rid of somebody, y'all. Anytime people come in and I know that they're scammers, I get rid of them. All right. They need volume. Volume in the vascular space, all right? So isotonic, when your patient has a high sodium and their cells are shrunk, what do they need? If they're shrunk, we need water in the cell to make it the pretty grape again, right? Okay, hypotonic, when your patient has severe low sodium, all right? Hang on, I just messed my paper up. Sorry. Good gravy. All right, hypotonic is when your patient has severe low sodium and their brain cells are swollen, okay? Their brain cells are swollen, their sodium is low. Hypotonic, when your patient has severe low sodium and their brain cells are swollen, what do they need? They need water pulled out of the brain cells because it is swollen. Hypertonic, the physiology tells you the answers. Do you understand? That one segment, if you reread that to yourself and rewrite it, put it on a flashcard, do whatever, that is going to help you. All right? Thank you for sharing the live. Okay? So let me give you the 3 types with their examples. Isotonic is like 0.9% normal saline, right? Lactated ringers and D5W in the bag. Okay? But I'm going to come back to D5 in a minute. All right? Because that's tricky. Hypotonic. Half normal saline, okay? And 0.33% normal saline, okay? And then you got the hypertonic, 3% sodium chloride, or D5 normal saline, D5 half normal saline, D10W and D50W, okay? The grape analogy is memorable and visual, okay? Remember your grape. You remember the grape swelling, and you remember it shrinking to the raisin. All right? When you get these tonicity questions, think about your grape. All right? So, we got the isotonic, because this is what you will use the most in clinical practice. Normal saline. 0.9% sodium chloride, okay? This is the workhorse of IV fluids, y'all. 0.9% normal saline is the workhorse of IV fluids. You use it for volume depletion, hemorrhage, shock, hypercalcemia, hyperkalemia, and as the only compatible fluid for blood transfusions. All right? Thank you for that, Chris. Thank you for that gift, love. Blood transfusion, 0.9% normal saline is the only fluid you can use. It's the only compatible. All right? The last point is critical. Write it down. If your patient is getting blood, the only IV fluid you can run with it is normal saline. Not LR, not D5W, normal saline only. Okay? Everybody got it. Don't croak nobody. No, if you get a blood transfusion reaction, you won't see. Why not LR with blood? LR contains calcium. Calcium causes the blood to do what? It'll clot in the tube. Okay? Why not D5W with blood? Well, dextrose causes red blood cells, hemolysis. We don't want to hemolysize them blood cells before we give them to the patient. It destroys the red cells. So, LR, blood transfusion equals normal saline, period, point blank. End of discussion. Got it? LR is the most physiological, similar to plasma. It contains sodium chloride, potassium, calcium, and lactate. You use it for burns. The Parkland formula for burn resuscitation uses LR. Use it for trauma and surgical patients. Avoid in liver disease. Okay? We avoid in liver disease and hyperkalemia. Why? Hey, what are the traps? Tara Kitchen Adams, I am currently teaching about fluids, but I did just post a video in response to the traps if you'd like to go to my profile and watch them. Thank you. I appreciate you. Okay, I did a whole video for the traps, baby. All right. You're welcome, honey. You want to avoid it in hyperkalemia and liver disease. Why? Why? Because it has 4 milliequivalents of potassium per liter. If your patient already has high potassium, you don't want to give them more. Don't give them more if they're hyperkalemic. Does that make sense? Okay. Right? All right. D5W, 5% dextrose in water. This is the one that confuses students, and the NCLEX knows it. In the bag, D5W is isotonic. Y'all need to listen. It won't cause hemolysis when you infuse it. But once it's in the body and the dextrose is metabolized or used up, what's left? Just water. Free water. Right? Because the dextrose is all used up. And free water is hypotonic. So D5W acts as a hypotonic fluid in the body. You use it for hypernatremia, right? High sodium, because the free water dilutes the sodium. Use it for hypoglycemia as a maintenance fluid. You don't want to use it for head injuries. The free water will worsen the cerebral edema. Okay? Got it? Get it, got it, got it? Here's a critical. I need you to know. D5W is isotonic in the bag, but hypotonic in the body. This is the most tested IV fluid fact on the NCLEX. I'm going to say it again. D5W is isotonic in the bag, but hypotonic in the body. This is the most tested IV fluid fact on the NCLEX. Students who miss this choose D5W for volume expansion. Wrong. D5W does not expand the vascular space. That's the most missed question. Okay? Got it? All right, we're going to wrap up. Okay? I'm going to talk about hypotonic and hypertonic really quick. Hypotonic, half normal saline. Skylar, stop doing that in front of me, and I'm over here trying to teach. I got ADHD just like you. You're flipping in my face. Half normal saline, 0.45% water moves into the cells. Use this when the cells are dehydrated. When sodium is high and the cells are shrunken, okay, hypernatremia is the classic indication. Also used in DKA maintenance. After you've restored the volume with normal saline, you switch to half normal saline to replace the cellular fluid deficit. When do you never use hypotonic fluids? Head injuries, okay? It increases the intracranial pressure. If you give hypotonic fluid to a patient with a head injury, water rushes into the brain cells. They swell and you worsen the cerebral edema. That can cause a herniation or even death, okay? So you don't want to give hypotonic fluids in brain injuries. That's likely to be a question. Also avoid hypotonic fluids in shock. If your patient's in shock, they need volume in the vascular space. Hypotonic fluid will leave the vascular space and go into the cells. Okay? That makes the shock worse. Isotonic for shock always. Isotonic for shock always. Isotonic for shock always. Hypertonic fluids, 3% sodium chloride. Water moves out of the cells. This is a high alert medication. Hypertonic fluid, 3% sodium chloride is a high alert medication. It will be on your NCLEX. Use it for severe symptomatic hyponatremia. These are people that we just can't get their sodium back together, okay? Sodium below 120. Why? Because we don't want them to have seizures, right? Or altered mental status. The water moves out of the brain cells, reducing the cerebral edema and raising the sodium. But here's the rule. Correct it slowly. Remember, low and slow. 8 to 12 milliequivalents per liter per 24 hours, period. If you do it too fast, you cause the old dirty salt, right? Remember, the ODS, osmotic demyelination syndrome. Permanent neurological damage. You cause permanent brain damage, period. We talked about this in electrolyte class. 3% saline should be given through a central line or a larger peripheral IV. Never rapid infusion. Never IV push. Welcome in, Margaret. D50W. 50% dextrose is hypertonic and is used for acute hypoglycemia in the unconscious patient. You give it IV push, it rapidly raises the blood glucose. This is the one situation where you give a hypertonic fluid by IV push, but that's because you're treating hypoglycemia, not a fluid imbalance. Okay? Got it? All right. It's 5:36. All right? Y'all make sure y'all practice. Make sure to message me what we're talking about tomorrow. All right? Everybody, if you don't have my comprehensive review, I highly recommend you go get it. I want you all to listen to me. Ask your classmates. Chris has it. I'm just letting you know. I highly recommend it. I work, can I do what, baby? I work Friday, Saturday, Sunday normally, but we were super short, so I picked up. I take the NCLEX next week. I'm so nervous. Tara, go to the LINK in my bio. Chris is in here right now. They got my review. Yes, I will do psych tomorrow. They got my review. The LINK is in my bio. Go get it. It's everything you need. Come to class, 4:30 p.m. Eastern Standard Time. Yes, I'm going to do it for you guys. Yes, I'll do it. We can do live this weekend. Okay? Tara, I'm letting you know. I got you, 4:30 p.m. I know y'all got tests coming up. I'll go live Saturday and Sunday. I'll go live Saturday for sure. Sunday, we'll see. I might just post an informational video. Okay? Keisha, hello. Miley Leo, hello. Wanda, hello. All right? You're welcome, baby. All right, y'all. Don't forget Monday, the ticket on that comprehensive, okay? Psych tomorrow. If somebody else wants to add another topic, we can go on the whole class. But yes, if y'all go up there and get your daily heartbeat, you can set my notification bell. So if I do a pop-up live, it will. You're welcome, baby. It will automatically notify you. You go do the link in the bio. Go do your daily heartbeat. If you drop down, how many questions is on the comprehensive? All together, let's see, 300, I think. Because the reason that I don't have the exact number is because I added dimensional analysis. So you got the med part in there too. Casey, the IV fluids, I just gave it to you, baby. Oh, you're in Central Time? Did you get today's stuff? If you got today's stuff, it's in there. Okay? Today's class material, it's in there. Okay? How do you get it? Go to the LINK